So the risk factors for premature ovarian failure or for diminished ovarian functioning, primarily age. And while it is normal for the ovaries to diminish in their functioning as we get older, for them to be behaving like they're 42 when we're 35, that would be a little premature. Genetic conditions can arise, like if somebody has a genetic condition, rather, that is again that kind of corrupt hard drive. The gene is not changeable anymore. Those patients will have things like Turner syndrome, Fragile X premutations. Now, someone with Turner syndrome is never going to have ovarian function. They're not able to, they'll never have a menstrual cycle. So that's a genetic factor that causes premature, not just failure, but, lack of ovarian function at all. Fragile X permutations can lead to ovaries that function improperly or start to prematurely decline. Smoking and secondhand smoke exposure is a risk factor. So a surgical history like endometriosis, having an endometrioma excised from the ovary itself can lead to premature ovarian failure because it's possible to damage the ovary in the process, which is why most doctors try to leave them alone unless they are just causing too much harm. Scar tissue that might be affecting the functioning of the ovaries. Autoimmune diseases, especially autoimmune diseases that impact the ovaries directly, like with ovarian antibodies, but really any autoimmune disease, thyroid autoimmune disease, adrenal autoimmune disease, all of these can have an impact. Lupus, rheumatoid arthritis, any kind of autoimmune condition that leads to overactivity within the immune system. And anyone with a history of chemotherapy or radiation, excessive amounts of chemical or pesticide toxicity, or viruses like mumps, which can lead to infertility. So the symptoms present similar to perimenopausal symptoms or symptoms of estrogen insufficiency, but you're going to be surprised to be seeing them in someone whose age doesn't match up to presenting in that way. And that's the tip-off. So somebody who comes in who should not be in perimenopause and they're having irregular periods, or they're telling you that they have severe night sweats right before their period, they wake up drenched, or they're having hot flashes sometimes, or intercourse is painful because they have dryness and the vaginal dryness, or they're really low libido, or all of these symptoms that you might associate with somebody who's having a real shift in their hormonal functioning towards menopause. Signs and symptoms you're not going to be surprised by in a 45, 47, or 50-year-old, but that you might be a little surprised by in a 32-year-old, 35-year-old. That's going to start suggesting to you, okay, these ovaries are not acting as they should based on this person's age. So what we want to do is figure out is there a reason and is there anything we can do about it? And if there's not, then what are we going to do to help them preserve their fertility? So diminished ovarian reserve or premature ovarian failure, they can sometimes be they can be used interchangeably, but they don't exactly mean the same thing, right? Diminished ovarian reserve just means that the ovarian reserve is a little lower than it should be for that individual's age. Premature ovarian failure means that the ovaries are starting to shut down the way they do in menopause, and that's happening too soon for this patient based on chronologically where they should be. So premature ovarian failure is diagnosed when the ovaries stop functioning before the age of 40. The result of that, just like menopause, is low estrogen levels, which then impacts the frequency of ovulation. So when someone's going through menopause, their ovulatory frequency starts to decrease and they don't get a period as often. So our periods are tied to our ovulation. Sometimes patients will have irregular or occasional periods. Sometimes it won't be a true period. They'll just they didn't ovulate, but maybe the lining has thickened up to the point where they have a breakthrough bleed. Conception is absolutely still possible with these patients. The number one thing they're going to be up against, just like any other patient, is their age. So diminished ovarian reserve is reflected in low AMH and low estrogen values. And the FSH might be normal because even though the patient may have low AMH, they may still be ovulating on a regular basis, and the health of those eggs is not abnormal. FSH only rises when the follicles don't respond to the stimulation that they're giving. So the job of FSH, which is follicle stimulating hormone, is to stimulate the follicles to grow. But as eggs age, those receptors on the outside that are responsible for taking up that FSH and responding by growing, they get kind of lazy, or they don't function as well, or there aren't as many of them. And so the FSH is saying, grow, follicle, grow. And the follicle's like, I'm not listening to you. I can't hear you. So then the brain sends down more FSH and says, grow, grow, grow. And the follicle's like, I'm not. Finally, enough gets sent down, it starts to grow. So FSH rises more in relationship to the health of the follicle. The health of the follicle is more of a reflection of whether or not that's going to turn into a chromosomally normal baby than the AMH level is. I hope you guys can follow that distinction between AMH and FSH. AMH is just saying there's not a whole lot of eggs in here, but when I give them FSH, they're going to grow just as well as they ever have. They're not affected yet. They're not behaving old. They're behaving like normal young eggs. There's just not as many of them. So we're looking at FSH more as an egg quality variable, and we're looking at AMH more as an egg quantity variable. As a practitioner, I am far more concerned with quality than I am with quantity. Quality gets people pregnant. Quantity is just a little performative. It doesn't matter. We need one. We need one healthy embryo to make a pregnancy. So it's not, premature ovarian failure is not synonymous with premature menopause. Premature menopause means the menstrual cycle ends and the ovaries shut down, and that's reflected in low estrogen, high FSH, as I mentioned, and very low AMH, and is generally irreversible. You can sometimes catch a patient who isn't quite gone all the way there and kind of harness things and bring it back, but I have not been successful with patients who have all the variables going against them, like their advanced age, they're over 40, their FSH is, 30 or 40 or 50, it doesn't matter, it's high, their AMH is 0.02, and they have really low estrogen and a thin lining. It's enormously difficult to get that patient back. But if you took away one of those variables and everything I just said was the case, except the patient was 30, you actually can. And I'll show you a case where that happens a little bit later. So premature menopause, where the whole system completely shuts down, is pretty difficult to overcome. But perimenopause, where there is still an opportunity to get things to revitalize, you really can get things kind of moving again for people.